Good day and welcome to this installment of the Gross Anatomy video podcast series. This is Dr. Stuart Ingles. Today we're going to be entering the leg region and looking at the anterior and lateral compartments of the leg. And because it's not going to be a particularly long lesson, we're going to jump ahead a little bit and cover the bones and joints of the foot as well for the sake of timing. Our objectives today is looking at the structures of the anterolateral leg with respect to adjacent structures, talk a little bit about the surface anatomy, particularly of some of the tendons that we'll see and feel crossing the ankle joint, describe the basic muscular attachments within the anterolateral leg, compartmentalize these muscles and describe their innervation, look at the main activity of the muscles and what effect different nerve injuries might have, describe the vasculature, and as said, we're going to be looking at the ankle joint as well as some intrinsic joints within the foot to describe the motions that occur there. As this is our first podcast, which is looking at the leg itself, we're going to take a moment to look at the different compartments of the leg that we'll be covering over the next two lessons. First, it's important to realize that there's two separate bones that are associated with the leg. We'll be talking about in detail in a moment. The larger tibial bone that we see more on the anteromedial side, and the smaller fibula, which is found a little bit more posterior and lateral to the tibia. The leg itself can be divided up into four distinct compartments based on function, innervation, and vascular supply. First, we have the anterior compartment. This is the bulge of muscle that's found on the anterolateral aspect of your leg, and when you pull your toes up, you can feel the muscles in this area tense. This is the compartment that houses the dorsiflexors, which are actual extensors of the ankle. These are the muscles that are responsible for pulling your toes towards the ceiling, which is the reason why these muscles become tight when you pull up on your toes. This is innervated by the deep fibular nerve, as we'll be talking about, and gets its vascular supply by the anterior tibial artery. Lateral to that, we have the lateral compartment, and these are the two compartments that we're going to be spending this podcast really discussing in detail. Lateral compartment houses the everters of the foot, so these are the muscles that pull the sole of the foot towards the lateral aspect. It's innervated by the superficial fibular nerve and receives its vascular supply from the fibular artery, which actually runs in the posterior compartment but extends adjacent branches over. When we go to the posterior aspect of the leg, we can actually divide this into two separate muscle groups based on the presence of this intermediate septum, which divides them off. First, we have the superficial posterior compartment, and this houses the plantar flexors. These are the true flexors of the ankle, innervated by the tibial nerve and gets its vascular supply from both the tibial and fibular arteries, depending on whether it's medial or lateral in location. Deep to that, through this intermuscular septum, we have the deep posterior compartment. The major difference, this is also innervated by the tibial nerve and also receives its vascular supply from both the tibial and fibular arteries. The principal difference between the two is that the tendons for the deep posterior compartment extend past the ankle joint itself and actually are long flexor tendons within the foot itself, similar to the arrangement that we saw at the hand. Time to look at the two bones that make up the leg itself. First, we have the tibia, shown here on the anterior and posterior surfaces. Tibia is the second largest bone in the body next to the femur, and it actually receives the weight of the femur itself and transmits it to the bones of the foot. Tibia has a large superior projection that's called the tibial plateau. Literally means a tibial shelf, and this actually contains the slightly concave medial condyle and slightly convex lateral condyles of the tibia that articulate with the medial lateral condyles of the femur. And again, we see that intercondylar eminence containing the medial and lateral tubercles, and anterior and posterior to that, the attachment points for the menisci and the cruciate ligaments. A couple of prominent bony projections that we see on the anterior surface. First, we have the tibial tuberosity, which serves as the attachment point for the patellar ligament, and so consequently the acting point for the quadriceps femoris muscle group. Lateral and slightly superior to this, we have the anterolateral tubercle, also commonly known as the Gerdy's tubercle, and this serves as an attachment for the iliotibial band. As we move along the shaft of the tibia, we notice that it has a very prominent anterior border that represents the anteriormost portion of the shin, just medial to the anterior muscular compartment group. So anytime you bang your shin off of something, it's usually this anterior border that's being hit. We also have a prominent lateral or interosseal border, which serves as the medial attachment point for the interosseal membrane connecting the tibia and fibula together. Distally, we once again have a projection as the tibia transmits the weight to the bones of the foot. Prominently, we see the medial malleolus, which serves as a medial shelf over top to increase the surface area of contact between the tibia and the bones of the foot, producing the ankle joint. Smaller of the two bones is the fibula. It's not at all involved in weight bearing. The entire weight is transmitted directly into the tibia and right down the tibial shaft to the bones of the foot, but it does have extensive muscular attachments that we'll be noting as we speak. You have the head of the fibula proximally, which articulates with the tibia at this fibular articular facet, and the neck region, which is associated with the nerve that we'll be talking about today. Very thin shaft. We do have this prominent medial or interosseal border, which serves as the lateral contact point for the interosseal membrane. And then finally, it projects out once again into this fairly prominent lateral malleolus, which is actually larger than the medial malleolus and projects slightly inferior, once again increasing the surface area of contact for the ankle joint, which we'll be discussing later on. As we're on the subject of osteology, we're going to jump ahead a little bit and talk about the bones associated with the foot. A couple of reasons for this. First of all, we're going to be talking about a number of muscles that have their distal attachment to the bones of the foot, so it's prudent to talk to them at this point. We'll also be discussing the ankle joint and intertarsular joints a little bit later in this class, so consequently we can include the discussion of the bones of the feet alongside the bones of the leg region. Generally speaking, when we look at the bones of the foot, it's very similar and analogous to what we saw within the hand. And in the next lecture, we're actually going to be mentioning this, that there's a number of analogous structures and a lot of comparison can be made between the hands and the feet. A lot of similarities anatomically. We can divide the bones of the feet into the posterior tarsus bones, which are analogous to the carpal bones of the wrist and hand. The metatarsal bones intermediately, which are analogous to the metacarpal bones, and distally we have the phalanges, which are analogous to the phalanges within the hands themselves. Starting in the tarsus region, we have what's called the talus. This is the most superior of the tarsal bones. It receives weight from the tibia and redistributes it through the other bones within the feet. It has no muscle or tendon attachment to it, but it does have a number of articulating surfaces. We can divide it into a posterior body region, which articulates with the tibia and fibula superiorly and inferiorly with the calcaneus bone, a neck region separating the body from the head region, which projects anteriorly and inferomedially to articulate with the navicular bone. This head is actually palpable on the medial aspect of your foot. If you take off your shoe and feel in this area, it feels like a very hard mass, but it is somewhat hidden, particularly in inversion. But if you start to evert your foot, you should be able to feel it a bit more prominently. Next, we have the calcaneal bone, also known as the heel bone. So this is the largest and strongest of the tarsal bones. If you think about it, this accepts the weight from the talus and distributes it into the ground. So this is the end point for weight transferal to the ground when in a standing position, which is consequently why it has to be so strong. The anterior two-thirds articulate with the talus superiorly, and if we look at the underside, we can see this shelf region, which is known as the sustentaculum tali, or sustainer of the talus. So we can think of the talus as really kind of sitting on this shelf. So the importance of this is, first of all, support of the talus, but the real reason that it's present is, if you look on this medial view, we're going to be talking in the next lesson about a number of ligaments and neurovascular structures from the posterior compartment, which will pass medially to access the plantar surface of the foot. So they're able to pass under the sustentaculum tali, which prevents them from being crushed. Posteriorly, the calcaneus has a very large calcaneal tuberosity for insertion of the Achilles tendon, and we also see off the tuberosity the medial and lateral tubercles, which help in supporting the weight, when also creates a groove for muscle and fascial attachment. Moving anteriorly, we have the navicular bone. Gets its name because of its boat-shaped appearance. It has a concave posterior surface that articulates with the head of the talus, and a convex anterior surface which articulates with the three cuneiform bones. Medially, it has a very prominent tuberosity for muscle attachment. This is also palpable on the medial aspect of the foot in inversion or eversion. So this is how you're able to distinguish between the navicular and the head of the talus. Is in inversion, you should only be able to palpate the navicular bone. When you move to eversion and move your finger backwards, you should be able to also palpate the head of the talus, which disappears in inversion. The lateralmost of the tarsal bones is the cuboid. Once again, it has a prominent tubercle on the lateral aspect for muscle attachment, and distally we also see this groove which accommodates a tendon from a muscle in the lateral compartment as it accesses the plantar surface of the foot on the lateral side. Three cuneiforms. Cuneiform means wedge-shaped bone. It's not very prevalent in the diagrams we have, but from superior to inferior, they resemble keystones in that they're much wider superiorly than inferiorly. And similar to keystones, this creates a transverse archway. And so this is the bony structure that accommodates the transverse arch of the foot. Once again, to provide some depth to the plantar surface to prevent structures from being crushed, and also to serve as shock absorption during the planting of the sole of the foot during normal gait. Finally, we have the metatarsals and phalanges. This is very similar to what you saw in the hands, so it'd be redundant to really talk about them. Even the numbers, where we see 2 phalanges associated with the first digits and 3 with the digits 2 through 4. Couple of minor differences to mention. First of all, if we look at the tarsal metatarsal joint for the first metatarsal, when we saw the first carpal metacarpal joint, it was a saddle joint in the thumb region, which is what accommodated opposition. It's flat planar in the foot. There's no need for big toe opposition, so consequently we don't have the saddle joint arrangement that we do in the hand. Secondly, if we move down to the fifth metatarsal bone, we see a very prominent tuberosity once again, and this accommodates attachment of the other muscle from the lateral compartment that we'll be talking about later, and is a common site for avulsion fractures, actually. Look now at some radiographic images of the ankle joint and the associated joints of the foot. You can see in this diagram the tibia and associated fibula, and how the fibula projects a little bit inferior relative to the tibia. You can also see the dome of the talus, which articulates with the tibia and fibula to form the ankle joint. So this is the Mortean tendon joint that we had talked about. The outline of the calcaneus projecting posteriorly. The navicular bone and the associated talocalcaneal navicular joint that we talked about, and the medial cuneiform articulating with the first metatarsal as well as the fifth metatarsal and its rather prominent base. Switch now to a lateral view of the ankle. Again, you can see the tibia and the fibula superimposed on one another. The outline of the talus, which gives you a bit of an appreciation for that concavity on its inferior surface and the convexity of the calcaneus, and the tarsal sinus, which contains those interosseal ligaments that we discussed. Head of the talus is also prominent as it articulates with the navicular bone, and the superimposition of the first, second, and third cuneiforms, or medial, intermediate, and lateral cuneiforms respectively. And once again, we can see that base of the fifth metatarsal. MRI image of the ankle as well, showing the lateral malleolus, the tibia, And this also gives us an appreciation for the medial and lateral collateral ligaments. Specifically, we can see the posterior talofibular ligament, the calcaneofibular ligament, the peroneal tendons, and the tendons that cross behind the medial malleolus, specifically the tibialis posterior in this diagram. A couple of images from your textbook to display the vascular supply for the leg. We're going to discuss the vascular supply for the entire leg, even though we're not looking into the posterior compartment until next podcast, simply because it all fits in functionally together. First artery to be aware of is the popliteal artery, and we'll be discussing this more in the next podcast, but this is a continuation of the femoral artery. If you remember back, we talked about the femoral artery passing through the adductor hiatus formed by the adductor magnus muscle. As it does, it receives a name change, so as we see it along the posterior surface of the knee, it's called the popliteal artery. This will continue into the leg posterior to the knee joint. A couple of reasons for this arrangement. First of all, if we had a major vessel traveling along the anterior surface of the knee, it would be susceptible to very serious vascular damage anytime that you'd fall on your knees during a trip or during athletic competition. So this provides a level of protection to this large artery. Secondly, it allows us to keep our knees in a bent position, such as with sitting, without stretching the artery and compromising vascular supply to the remainder of the leg. Now, even with this arrangement, we still need to get vascular blood supply to the anterior portions of the knee, and we accomplish this through smaller branches known as genicular arteries. So we have a superior medial, superior lateral, inferior medial, and inferior lateral genicular artery, which we'll be able to identify in lab from the posterior aspect. And these wrap around the patella and anastomose and provide a very thin capillary network. Again, incredibly small arteries that are relatively protected, so even if there is any damage in this area, it's not going to be as severe as damage to the much larger popliteal artery. Popliteal artery then continues into the leg. At this point, it's going to split into an anterior tibial artery, which will then pass between the tibia and fibula, just proximal to the start of the interosseal membrane. So we have this interosseal membrane, but it's not complete up the entire length of the tibia and fibula. We do have this hole at the top that allows the anterior tibial artery to pass through and gain access to the anterior muscular compartment, which is the vascular supply for the anterior compartment. It will then continue down and pass into the dorsum in the foot, producing an artery known as dorsalis pedis. Major artery supply to the dorsum of the foot, and it's also of clinical importance in that if we're testing for potential vascular compromise, this is a pulse that's going to be taken to see if there's anywhere along this length that the vascular supply is being pinched off. Moving back to the posterior compartment, the secondary branch that we see is the posterior tibial artery. So popliteal artery branching into an anterior and a posterior tibial artery, which will run along the posterior aspect of the tibia. And we do have an additional branch given off in this area that will run more on the lateral aspect, and not surprisingly, we're going to call this the fibular artery. So the posterior tibial artery and smaller fibular artery will give vascular supply to both the superficial and deep posterior compartments of the leg. In addition, the fibular artery will also send muscular branches to the lateral compartment to supply the muscles found within the lateral compartment as well. Finally, note that the posterior tibial artery will continue past the leg into the plantar surface of the foot, in which case we call it the medial and lateral plantar arteries, supplying vascular supply to the intrinsic structures of the plantar surface of the foot. A couple of diagrams out of your textbook that demonstrate the innervation pattern to the entire lower leg. Again, similar as what we saw with the arteries, we're going to discuss these all at the same time because it does just make more sense based on their branching pattern. First, we see the continuation of the sciatic nerve. Now, if you remember from what I said in the previous podcast, the sciatic nerve is actually two separate nerves that are bundled together. But when we get to this popliteal fossa, we actually see them separate for the first time and can identify them individually without having to split that epineurium. First, we have the tibial nerve. So the tibial nerve is going to continue in the posterior compartment, posterior to the tibia, and it will lie between the superficial and deep posterior compartments along with the tibial artery, very close to these. It sends numerous muscular branches and is responsible for the entire innervation for the posterior compartment musculature, both superficial and deep. It will then continue posterior and inferior to the medial malleolus to be able to gain access to the plantar surface of the foot, in which case it branches into medial and lateral plantar nerves, and this is responsible for innervation of the entire plantar muscular compartment. Moving back up to the popliteal fossa, we see the common fibular nerve. It branches off and runs laterally, disappears underneath the lateral head of the gastrocnemius, as we will be talking about, and then we actually see it pass superficial to the neck of the fibula. So it actually lies very superficially, and if you were to take your hand, identify the head of the fibula, move down to that so that you're in that fleshy neck region where we see the lateral compartment begin. If you were to press a little bit and rub anterior and posteriorly, you don't want to push too hard, you can end up damaging the nerve, but if you push lightly and rub back and forth, you'll probably notice a tingling sensation down the leg, and that's because of the pressure that you're putting on this common fibular nerve. We can pick up the common fibular nerve along the anterior aspect of the leg now, where it branches into a superficial fibular nerve which stays within the lateral compartment of the leg and supplies innervation to the muscles of the lateral compartment, and a deep fibular nerve which will run into the anterior compartment and is responsible for innervation to the anterior compartment musculature. Note as well that the deep fibular nerve will also send a branch into the dorsum of the foot and is responsible for the innervation of the muscle we find in the dorsum of the foot. Turning our attention to the anterior compartment, this is the fleshy region that's found in the anterolateral aspect of your leg, just lateral to the tibia. As we just discussed, it contains this neurovascular bundle that's found deep to the musculature, just anterior to the interosseous membrane connecting the tibia to the fibula. So this would contain our anterior tibial artery as well as our deep fibular nerve. The specific muscles that we'll be looking at in the next couple of slides are the medially oriented tibialis anterior, the laterally oriented extensor digitorum longus, and the deep extensor hallucis longus. Using Netter's diagram now to look at the anterior compartment musculature. The most prominent muscle in this compartment is the tibialis anterior. So if you were to dorsiflex or pull your ankle up towards the ceiling and also slightly invert, this is the muscle that's really going to pop out in the anterior portion of the leg, just lateral to the tibia or shin bone. Tibialis anterior, as we said, is a dorsiflexor and an inverter, and you can actually palpate and feel that tendon as it projects down and attaches along the medial cuneiform and the base of the first metatarsal. It has its origin point off the lateral surface of the tibia, as well as the medial portion of the interosseal membrane. Next muscle in this series is extensor digitorum longus. Very long origin point off the shaft of the fibula, and from there it projects out, forming 4 separate tendons which will project to each of the 4 digits 2 through 5, going to assist with dorsiflexion or pulling up of the ankle, but in this case it's also going to be an extensor of digits 2 through 5. Next muscle in this group is extensor hallucis longus. This is a extensor which sends a single tendon to the dorsal surface of the base of the great toe. Similar to how we use pollicis to describe the thumb, hallucis is the term to describe the great toe, and so this is extensor hallucis longus. It has an origin point off of, once again, the medial surface of the fibula, but also the lateral surface of the interosseal membrane. Much shorter than the tibialis anterior or extensor digitorum longus, and it only has that single tendon which runs through. Finally, we do have one other small muscle to be aware of. This is called the fibularis tertius, and what it is actually part of the extensor digitorum longus muscle, but some of the fibers project to a second tendon which reaches the little toe. And in this case, rather than going to the distal phalange, it will actually insert along the proximal dorsolateral surface of the fifth metatarsal. Rather an insignificant muscle. It's not going to contribute much, just a small amount of dorsiflexion. The thing to be aware of, though, is it shares its name with muscles in the lateral compartment that both have fibularis in their name, but this is truly an anterior compartment muscle. It's associated with the other muscles in the anterior compartment and has the same innervation, the deep fibular nerve, so trying to get it confused with the lateral compartment musculature. We now turn our attention to the lateral compartment. If you feel your leg, this is the fleshy region that's found on the lateral aspect of the leg. As we talked about earlier, it does contain the superficial branch of the fibular nerve, but notice that there's no arterial supply. And remember from previously, we talked about the fibular artery that's found in the posterior compartment, communicating branches at different regions to supply the muscles in this area. We're going to talk about the two muscles found in the lateral compartment. First, we have the superficial fibularis longus, and then the deeper running fibularis brevis muscle. Netter's representation of the lateral compartment. This contains two muscles, both with fibularis in their name. First, we have fibularis longus, so this muscle will be more superficial of the two, and the tendon will pass posterior to the lateral malleolus, will wrap underneath the plantar surface of the foot. If you remember back, we talked about the cuboid bone and the distal groove for a tendon to pass. This is the tendon that we were talking about, the fibularis longus. It will then run and attach to the underside, the lateral aspect of the medial cuneiform and the base of the first metatarsal bone. And so consequently it attaches basically on the opposite side of tibialis anterior. And because of the line of pull, it's going to be a plantar flexor as well as an everter of the foot. Fibularis brevis lies underneath fibularis longus, originates off the lateral shaft of the fibula, more distal as compared to fibularis longus. This tendon will also pass posterior to the lateral malleolus, and in this case will insert on the base of the fifth metatarsal bone. If you think back to the osteology section, we mentioned that the fifth metatarsal is sometimes fractured in what's called an avulsion fracture, in which a tendon is able to rip part of the bone away. So this is the tendon that is in question. You can palpate these two tendons if you find the lateral malleolus and go just anterior and inferior to the lateral malleolus, and then repetitively evert your foot, which is to pull the sole of the foot outwards and relax. You will actually feel these tendons become taut and slack as you do so, and you'll be able to palpate them. Fibularis brevis is also a plantar flexor and a weak everter of the foot. And both muscles, being part of the lateral compartment, will receive their innervation from that superficial fibular nerve. One final note before we leave this section, you will often see textbooks talk about the peroneus longus and brevis muscle. So peroneus is an antiquated term which was often used to describe these muscles as well, and you might see it pop up. You'll actually hear me say it quite a bit. When I first took anatomy, this was still the term that was commonly used, and I slip into old habits and consequently will call this peroneus longus and brevis. And if you remember back, we also have the tendon here for peroneus tertius coming off, but again from the anterior compartment. So if you do hear those, either from myself or someone else, it's synonymous with fibularis longus and brevis, and not something to be too concerned with. This Netter image is just a summary slide for the anterior and lateral compartment, so no new information, just summarizing what we've already talked about. You can see in the anterior compartment we have the tibialis anterior muscle and the extensor digitorum longus, as well as extensor hallucis longus muscle. And in this case, the tibialis anterior and extensor digitorum longus have been separated and peeled apart, so you can see the neurovascular bundle here, containing the anterior tibial artery and the deep fibular nerve. In the lateral compartment, we have the fibularis longus muscle superficially and the fibularis brevis more deep to the fibularis longus. And when we pull back the fibularis longus muscle, we can see the innervation from the superficial fibular nerve. And remember, once again, that there is no major artery. It receives its vascular supply from communicating branches from the fibular artery. Finally, if we trace the superficial and deep fibular nerves back up, we can find that common fibular nerve as it passes along the neck of the fibula. I'm going to switch gears now and look at the ankle joint. This is a synovial hinge type joint that we see as an articulation between the tibia, fibula, and the talus. So as we previously described, the actual weight-bearing portion comes through the shaft of the tibia directly into the talus, but we also have that medial malleolus and lateral malleolus associated with the fibula, which also articulate with the talus on the medial and lateral surfaces, respectively. The ankle joint is often described as a mortise and tenon design. This is going back to traditional architecture where a mortise is a square hole and a tenon is a square peg which fits into the hole. You see it a lot with log cabin designs and such, and if you look at the actual joint architecture, it does have that square sort of appearance to it. Because it is a hinge type joint, we primarily see dorsiflexion and the plantar flexion. So this may be a little bit confusing at first, but the plantar surface of the foot is actually synonymous with the palmar surface of the hand. So if you imagine this being the palm of your hand and these the fingers, what this looks like is actual extension of the wrist. And in fact, dorsiflexion is a special name given to extension at the ankle. So this is actually considered ankle extension because of the comparison to the wrist, but it is given the name typically dorsiflexion. Whereas plantar flexion, if you once again consider this as being the palm of the hand, this does represent flexion at the wrist and also represents flexion at the ankle. So plantar flexion is true ankle flexion, whereas dorsiflexion is actually ankle extension. It does create a bit of confusion, but thinking back to what we just talked about with the muscular groups, it's going to help you to sort out the extensors versus the flexors in the anterior and posterior compartments, respectively. Something else to point out with this diagram is the shape of the talus. So when we look at dorsiflexion, you notice that the tibia and fibula are articulating with the anterior surface of the talus, whereas in a plantar flex position, the tibia and fibula are articulating with the posterior aspect of the talus. If we look at the talus using a superior view, what you'll notice is the actual joint architecture is wedged shape, so that anteriorly the distance between these two lines is greater than what we see posteriorly. What this means is when you're in a dorsiflex position, it's this wider anterior portion which is wedged between the tibia and the fibula, and so consequently it creates a tighter fit. Whereas in the plantar flex position, it's the narrower region of the talus which is articulating with the tibia and fibula, and so consequently in a plantar flex position you have a little bit more wobble or joint play between the talus and the tibia and fibula. You can demonstrate this for yourself by taking your own ankle and putting it into dorsiflexion. You'll notice that you don't have a lot of ability to wiggle it around, but then when you switch your ankle to a plantar flex position, in addition to that flexion extension, you'll notice that you have a little bit of wobbling, meaning that you can slightly rotate the joint, slightly invert and evert, and that's because of the decreased space between the talus and the tibia and fibula. The ankle joint itself is reinforced by collateral ligaments, similar to what we see at the ankle. This is a view of the lateral aspect, and we have 3 separate bands of lateral collateral ligaments, which are given individual names. First, we see the anterior talofibular, which runs from the lateral malleolus to the anterolateral aspect of the talus. Second, we have the calcaneofibular, which runs from the lateral malleolus inferiorly to attach to the calcaneal bone. And not very well shown in this diagram, we also have a posterior talofibular, which will connect the talus and the fibula posterior to the lateral malleolus. Moving along to the medial aspect, we have a very broad medial collateral ligament, which is known as the deltoid ligament. So unlike what we saw on the lateral surface, it's one long continuous band of connective tissue that has that deltoid appearance similar to the muscle that we see at the shoulder, hence the name. Now we can actually divide this up into separate bands. First, the anterior tibiotalar, coming from the medial malleolus to insert on the talus, the tibionavicular, which runs down to attach to the navicular bone, tibiocalcaneal, which runs from the medial malleolus to the sustentaculum tali, and finally the posterior tibiotalar, which runs from the medial malleolus to the posterior aspect of the talus. Now, having said that, all of these bands are actually one continuous band that is known as the deltoid ligament. So while we are able to separate it out, it's not nearly as distinct as the bands as we see on the lateral aspect. In addition to the ankle joint, there are a number of intricate joints associated with the foot itself. Obviously, we have the hinge joints between the metatarsals and the phalanges, similar to what we saw in the fingers. But again, similar to what we saw in the carpal bones, there are subtle yet important movements that are also associated with the intertarsal bones themselves. The majority of them are very, very small gliding type motions. It's reinforced by a number of strong ligaments, so there's only a little bit of wiggle room. But there are a few joints where we see much more prominent motion that we need to discuss. First one is what is called the subtalar joint. This is an articulation between the inferior surface of the talus and the superior surface of the calcaneus. We can actually divide this up into two separate regions. Posteriorly, we have what's called the anatomical subtalar joint between the body of the talus and the calcaneus. But as we move forward, there is a small articulation between the head of the talus and the calcaneus as well. So the entire compound joint itself is known as the talonaviculocalcaneal joint. There's a mouthful for you. And this is specifically the talocalcaneal portion of that joint. The two joints themselves actually function and work together so that we have very predictable movements at both joints, but they are separated and are considered two completely separate synovial joints. This is showing another image of the talus here. We can see that that posterior surface is quite concave as compared to the calcaneus, which has a more convex association with it. So when we do see movement here, it is a gliding type movement, but it tends to be on a bit of a pivot. So if you imagine somewhat similar to a saddle, if you were riding saddleback and were to move from one side to the other, you would create a lean where your body would lean one side or to the other. In between the anterior and posterior articulating surfaces, we have this region known as the sinus tarsi, and we see a very strong interosseous ligament which binds here and connects the tarsus to the calcaneus. We see it conceptually being stretched out in this situation, but normally this would lock these two bones very, very tightly together. And as well, within the joint capsule itself, we have a number of talocalcaneal ligaments which help to reinforce the joint. As we see, we do get a gliding motion, but it's not purely back and forth. It actually occurs at a bit of an angle. So this complex image is trying to show the compound joint and how the motions at the two joints really create a rotational motion along this theoretical axis. It actually starts lateral and inferior and then runs medial and superior through the head of the talus. We know this is the axis of Hankey, and so movement of the talus back and forth is more of a rotational affair, and it does occur along this axis. So the subtalar joint is what is responsible for the movement of inversion or eversion of the foot. So if you were to look at your foot right now and go from inversion to eversion, you'll notice that it's not a true back and forth motion. It's actually on a bit of an angle which corresponds to this axis of Hankey. So this is an important distinction to make. The ankle joint itself allows flexion and extension, and that's it. Pronation and supination is actually a product primarily of the subtalar joint. Next, we're going to look at the transverse tarsal joint. This is actually a combination of two separate joints. First, we have the head of the talus bone articulating with the navicular, but secondly, we also have the anterior portion of the calcaneus articulating with the cuboid. These tend to be in the exact same geometric plane, and so consequently, they tend to move as a functional unit rather than as individual joints, and so consequently, we give the combination of the two, a compound named the transverse tarsal joint. Transverse tarsal joint is actually what divides the foot into a midfoot and a hindfoot region, and it also permits, between the two joint surfaces, rotation within the coronal plane, such that the navicular and cuboid are able to rotate coronally around the talus and calcaneus. And so again, this is a form of pronation and supination, and what we see is that movement at this joint accentuates pronation and supination that was seen at the subtalar joint, so that the degree of pronation and supination is greater when looking at the midfoot, forefoot region than when looking exclusively at the hindfoot region. Finally, we have the tarso-metatarsal joint. Very, very limited movement here, but it does once again create this boundary which allows us to distinguish the midfoot from the forefoot region. There's a number of clinical correlations that we see at the ankle and foot region, but in particular we're going to look at ankle sprains because of their prevalence. These can be divided up into different types. First, we have what's typically called the inversion sprain. This is the most common type of sprain in the entire body, and it's the result of a hyperinversion which ends up tearing the lateral collateral ligaments. It occurs typically during running and jumping motions and usually involves a certain amount of plantar flexion. So remember back to what we talked about a few slides ago, how the talus is much wider anteriorly than posteriorly, and that in that plantar flex position you have a bit of wobble room. This creates a certain degree of instability that makes the ankle more susceptible to injury in this position. If we look a minute at the mechanism of injury, normally we have the tibia, which is lying on top of the talus, which itself is lying on top of the calcaneus. And normally we have a direct transfer of weight through the tibial shaft down into the calcaneus. If we look at what happens when an individual lands with a certain degree of inversion, we now still have the tibia directly on top of that talus, but now the calcaneus is out at a bit of an angle, and so consequently the force vector is now outside the basis of support of the calcaneus, and this is going to create a rotational type of motion, a torque motion that creates a varus stress at the ankle, as we're seeing here. So when you're inverted, the base of support is in this position, and so consequently there's a tendency to generate torque. This is normally resisted by the lateral collateral ligaments, but if the amount of force that goes into the foot exceeds the strain capacity for the lateral collateral ligaments, it's going to result in tearing, and this is the classic example of an inversion sprain. Varying degrees of inversion sprain depending on the severity of the injury. First, we have what's called a grade 1 sprain, and this is where we see typically what we call micro tearing within the anterior talofibular ligament and quite often in the calcaneofibular ligament as well, depending on the specific biomechanics of the injury. This is the most common type of ankle sprain. Most of us have encountered it at some point in our lives, and it results in a bit of pain and discomfort and immediate swelling because of the microtrauma, but there's no joint instability. The individual is usually able to walk around without too much difficulty, but there's point tenderness for a few days or a couple of weeks. Second degree tear is where we have partial tearing within the anterior talofibular ligament and sometimes within the calcaneofibular ligament. So rather than these micro tearing, there is some compromise to the actual ligament itself. It's not a complete tear, but a large portion of the ligament has been completely torn through. This would create much more severe pain, point tenderness. The individual would have significant difficulty walking on it immediately afterwards. But again, so long as the ligaments are partially intact, there should not be a dramatic loss of stability. Maybe a little bit of joint laxity, but not a complete loss of stability. In the third degree ligament tear, we see complete tearing of the anterior talofibular ligament and sometimes the calcaneofibular ligament, once again depending on the biomechanics and the severity of the injury. And in this case, it's going to be significant pain. The individual is not going to be weight-bearing, and there's going to be great joint instability. A typical test is what's called the anterior drawer, where the physician will stabilize the tibia and fibula, put his or her hand behind the calcaneus and pull forward. And in the case of a grade 3, you will typically get subluxation of the ankle joint forward of the talus relative to the tibia and fibula. It's important to note that the anterior talofibular ligament is typically always affected in each of these injuries, where the calcaneofibular ligament might be affected to a lesser degree or not at all because of the mechanics. So in a grade 3, we might have complete tearing of the anterior talofibular ligament, but only partial tearing of the calcaneofibular ligament. Posterior talofibular ligament is not typically involved because of its strength and position, unless it's a very severe injury, such as a grade 3, where you might get micro or partial tearing of the posterior talofibular ligament. Textbook inversion sprain here, courtesy of Maria Sharapova. You'll notice that as she lands and takes a step on the left leg, she ends up with an hyperinversion that causes spraining within her left ankle. So we look at it again, you'll notice that as she takes that second step, this is pretty typical of what you would see with an inversion sprain. Her ankle is slightly plantar flexed, and she inadvertently steps with that lateral aspect of her left foot. So as a result, the force being generated through the tibia falls out of the base of support of the talus and calcaneus, and if we follow it through, it results in that characteristic inversion sprain that we typically see. Now, fortunately for Sharapova, in this particular situation, it looked pretty graphic, but it was actually relatively minor. So this was right after the injury occurred. She picks herself up, checks it, walking fairly gingerly because it is an incredibly sore injury, but that would be characteristic of what we would see with a type 1. It would probably result in not being able to continue with competition, and you need to ice and take it a bit easy, but it wouldn't create severe debilitation, or this wouldn't be what we would consider a career-ending sort of injury. Another example of an inversion sprain, also from tennis, but much more severe in this situation. I'm going to warn you that this is relatively graphic. You're going to be paying attention to the individual at the top of the screen. As we play through the video, and you see as he returns a volley, just drops in severe discomfort and holding the ankle, and you can see a bit of instability in the ankle in this view. And this is the reason why. You see as he plants, once again, goes forward in plantar flexion and inversion, and we have a significant inversion sprain where the ankle has gone beyond 90 degrees of inversion. You can see the sole of the foot out to the side here and the leg pretty much touching the court. So this almost certainly be a third-degree sprain involving complete rupture of the anterior talofibular, probably the talocalcaneal, possibly the posterior talofibular. It would also not be surprising if there were bone fractures associated with this injury as well. Eversion sprains are far less common than inversion because it's a far less common mechanism of injury, as well as the strength of the associated medial collateral ligament relative to the lateral collateral. It typically results from excessive valgus stress, as with an individual falling on the ankle from the lateral aspect while it's planted. And because of the strength of the medial collateral ligament, it's actually not uncommon to see an avulsion fracture of the medial malleolus, what is typically called a Pott's fracture. And this is commonly associated with the fracture within the fibula itself because of the distraction forces which would cause breaking typically within the fibular shaft. Finally, we have what's called an ankle syndesmosis injury, more commonly referred to as a high ankle sprain. And this is a bit of a misnomer because when you think about it, it doesn't really involve the ankle itself. It's actually the tibiofibular syndesmosis which is affected in this situation. The tibia and fibula are connected through some very strong anterior and posterior ligaments known as the anterior and posterior inferior tibiofibular ligaments. This injury typically results from a torsional movement which twists the talus inside of the Morti structure of the tibiofibular space, which results in separation of the tibia and fibula and can do damage to these ligaments. Here we see Gronkowski being tackled during the AFC Championship game against the Baltimore Ravens, and you'll notice that his ankle does get caught in this torsional movement. You can see it again from the lateral aspect here, and in this case Gronkowski did suffer a high ankle sprain because of that sort of injury. But when you get right down to it, when you look at what's also happening at the knee, he actually got off lucky in this situation. That concludes this 11th video podcast. I should mention as we're wrapping things up there, you probably noticed my voice changed quite a bit during that. This is actually recorded over a period of several days, and I'm starting to fight a little bit of a sore throat and some sort of bug. So if you thought there was a change in my voice and the overall tone, you're not mistaken. I'm just a bit under the weather while recording this. So on we go for the final video podcast recording for the term. We'll be looking at the posterior leg and sole of the foot. And keep your fingers crossed that I'm going to be on the mend. Otherwise, I might sound pretty raspy by the time the next podcast finishes up. Until next time, this has been Dr. Stuart Ingles. Enjoy the rest of your day.